hello, everyone. How are you? Glad to be here with you. Thank you for this wonderful opportunity. My lecture today is about Sagalign follow-up, troubleshooting, and elastics. First, I will introduce myself. I'm Sara Adnan. I had my bachelor degree 2010 from University of Baghdad College of Dentistry. My MSc degree in orthodontics from University of Baghdad, also 2020. Now I'm a PhD candidate in University of Baghdad College of Dentistry. I work at Ministry of Higher Education and Scientific Research at El Arkia University College of Dentistry. And I'm an orthodontist at Dental Home Clinic. First, let's talk about clear aligner. As we all know, that with the exposure to the outside world, with the exposure to social media, there has been an increase in aesthetic demand. A lot of patients came to us, want to improve their teeth and align their teeth to gain a perfect smile. Likewise, there has been an increase for the need of aesthetic appliances that overcome some of the limitation of the fixed orthodontic appliance, such as hygiene, appearance, quality of life, impact on quality of life. One of which are clear aligners. So what are clear aligners? Clear aligners are clear plastic appliances that use tooth-colored materials or handled, which are called attachments on the teeth, to move the teeth. Okay, clear aligners are not new. They have been introduced since 1945 by Kessling and evolved with time. Compared to fixed orthodontic appliances, clear aligners are more aesthetic because they are transparent and clear, so they are invisible, so most of the patients like them because of their appearance, transparency. Also, they are comfortable because the patient can remove them from their mouth on socially sensitive occasions, during eating, during brushing, when they have to attend a wedding or whatever. So they are extremely comfortable and the patient likes them. And since they can be removed from the patient's mouth, they are hygienic because the patient can remove them, brush their teeth, and reinsert their appliances. Also, clear aligners are considered as a safer appliance because less trauma, less laceration, there are no arch wires, no brackets, so less injury and safer generally. Also, clear aligners reduce treatment time and reduce chairside time because less management of wires and appliances and injuries and less frequent patient monitoring due to emergencies. But, however, clear aligners are highly dependent on patient compliance because if the patient doesn't wear the clear aligner, it will not work and it will be considered as a failure. Also, it has a limited control over root movement and complicated tooth movement, limited intermaxillary and sagittal correction, and difficulty in closing extraction spaces. However, most of these complications are not due to error in planning, but due to problems that evolved or occurred during treatment, such as poor follow-up and inadequate clinical control or delayed clinical control. Clear aligners has dramatically advanced with the use of buttons, at precision attachments, precision cuts, with the use of elastic, with the use of TADs, with the use of IPR, with the use of reduced amount of tooth movement per aligner. Initially, aligners was used only for treating simple cases, simple relapse cases, but however, now that's changed. Likewise, software are dramatically evolved, dramatically advanced, and now it is possible to treat very complicated cases with aligner. Even extraction cases, retraction cases, intrusion cases, and distalization cases are all possible now with treatment of with the use of aligner. However, in this lecture, we will focus on how to control follow-up during treatment rather than controlling planning, or also include some of planning advices. So, clear aligners in general require more clinical control as compared to fixed orthodontic appliance. How is that? Because clear aligners are highly dependent on patient compliance. You should check your patient compliance every visit. Also, it's highly dependent on clinician follow-up, checking the appliance, checking the attachment, checking the fits every visit. Also, and it's highly dependent on careful clinical intervention. So, as we said, we will focus on follow-up and clear aligners. What do we mean by follow-up? Follow-up is not just changing aligners, seeing the patient every 10 days, seeing the patient every 2 weeks, and giving them a new appliance. No, it's not. It's an active clinical intervention and active clinical control. The clinician should be able to know what to do, not only changing the aligners. Every visit, the clinician should be able to identify fit evaluation, tracking assessment, attachment monitoring, and assessment of patient compliance. We will address every point of these in the following slide. Follow-up schedule. What do we mean, or how often we do follow-up for our patient? To me, I do follow-up after 1 week or 2 weeks after insertion of the clear aligner to check the management, how the patient handle or how the patient use the clear aligner. Is there any attachment loss? Because most of the attachment loss occurred during the first 2 weeks, and the patient don't know. He is not yet able to identify any error in the treatment because he is still adapting to the appliance. So I recommend a first visit after 1 to 2 weeks. Then the routine visits are done every 4 to 6 weeks. You can do it every 2 months. It's possible, but not from the early beginning of the treatment. Make sure that the patient is compliant, is using the aligner correctly, cleaning the aligner correctly, using the chewies correctly. Then after that, you can give a longer appointment interval. So, what to check every visit? As we said, we should check. First thing to check is aligner seating. Complete seating of the aligner is essential. The aligner should fit the tooth typically. No gaps, no rocking between the aligner and the tooth. Likewise, no gap between the aligner and the attachment. Attachment should fill the aligner. Any gap, any rocking, any defect in the seating, that means that there will be a loss of track sooner or later. and the treatment will fail, and you will need to redesign, taking another impression, or repeat the treatment. We might reach that point. Also, we should check for tracking. Tracking means is the tooth move as planned? Mostly, the most important teeth to check are the incisors, the premolars, and the posterior teeth, and the canines. The canines and the premolars are extremely difficult teeth in rotational teeth movement because of their conical shaped roots. That makes tooth movement very difficult during rotation. Therefore, uh, rotation tracking should be checked carefully during each visit. If you see a loss of track, the tooth is not following the planned tooth movement, there is an issue. There is an issue, could be in patient compliance, could be in attachment design, could be in amount of IPR that you perform during the treatment. We will address all of this point in the few coming slides. Another important aspect to check in every visit are the attachments. Attachment should be checked for integrity as well as for the presence. Are they present or are they lost? Sometimes detachment occur. Patients lose their attachment and they didn't recognize it because it's clear and it's invisible. So it's your responsibility to check the presence or the absence of the attachment. In some cases, there will be wear of the attachment due to poor quality of composite or due to occlusal issue, such as occlusal interference or whatever that lead to attachment wears. Therefore, it's your responsibility to check your attachment. If there is no attachment, error in attachment or attachment loss, that's mean lack of planned tooth movement. Tooth movement will not occur. Simple tooth movement, proclination, retroclination might occur, but rotational, impossible, extrusion, intrusion, it will not occur. Also, we should check the patient compliance. The first point, as we said, from the disadvantage or limitation of clear aligners are their highly dependence on patient compliance. Patient compliance is a great issue in clear aligner. Patient should be internally motivated, should want to make a change in their smile. If they don't want to make a change, a real change, they are not internally motivated, they will not wear the appliance, and they come to you telling that the appliance is not working, there is an issue in your treatment. Also, the patient should be instructed to wear the appliance at least 22 hours per day, 20 to 22 hours per day. But you tell them 22 and they will wear it 20 because they will remove our from themselves. Likewise, elastic wear is also essential. Inconsistent elastic wear might lead to loss of track, incomplete rotation, and lag in rotational tooth movement, lags in sagittal correction. All these points should be addressed, and the patient should be instructed about importance of compliance. And you should tell the patient that if you didn't wear your elastics or your appliance, it will not work. Appliance clear aligners does not work alone, and they require this auxiliary and require your compliance. Another important aspect to check is the IPR. IPR and clear aligners are digitally planned, so you do not have to do it by yourself, plan it by yourself. It's digitally. It's all written in the planned treatment as you receive it. But however, the application and the correct procedure depends on you. You should perform as exactly as the paper or the instruction says. It's vary from 0.2 to 0.5 according to the case, according to the planned tooth movement. I recommend and you should use leaf gauge. Leaf gauge is essential to determine the exact amount of IPR that you do, interproximal reduction. Multiple leaf gauge are essential, not only one, because if you use only one, you will displace the tooth and give you a false indication of the exact amount of IPR. I use two leaf gauge, one from the mesial to the tooth, one for distal to the tooth. So when you put the first one, the tooth will not be displaced distally. When you put it mesially, it will not be displaced distally. The IPR, as we all know, is essential with the clear aligner or any type of tooth movement to create a space because, as we know, majority of the cases in clear aligner are treated without extraction to improve alignment and tracking and to reduce black triangle. I receive a lot of question about my case is spacing. Why do I have to do IPR? My case, I don't have severe crowding. Why do I have to do IPR? IPR is not for only biomechanical. It's essential biomechanical tool, of course, but sometimes we do it for cosmetic purposes, such as reducing black triangles or to prevent tooth collisions during digital planning. So, what are the early signs of loss of tracks? Loss of track, meaning that the tooth is not following the digital planning. What are the early signs of loss of track? The earliest sign of loss of track is called halo effect. What is the halo effect? Halo effect means there is a gap between the tooth and the aligner, and your aligner is not fit exactly with the tooth, resulting in incomplete incisal seating. Why halo effect is occur? Majority of the cases, it's occur due to poor fitting of the appliance, maybe due to poor compliance of the patient, maybe due to error in attachment design. All these points should be identified and addressed carefully. If it's a compliance issue, you should instruct your patient to comply with the aligner and be compliant and wear the aligner as planned 22 hours per day. It's a seating issue. You should instruct your patient to use the chewies. Chewies are not just a tool in the aligner box. No, they are essential tools and they play an important role in attachment seating, in the aligner seating. If it's an error in attachment design or attachment loss or wearing of the attachment, you should correct that point from the beginning. So all these points should be carefully noticed. Another sign of loss of track is lag in rotation. Rotational tooth movement in aligners are one of the most complicated tooth movement in aligner. Why is that? Because aligners are generally plastic material. It does not offer a very good control over the tooth to produce a rotational tooth movement. However, with the use of couple force system, with the use of wider attachment that will produce the desired moment to produce the rotational tooth movement, with the use of elastics, all these points has been addressed, and aligners nowadays are capable of producing an efficient tooth movement and efficient rotational control. But you should carefully monitor the case. Clinical monitoring is essential. Another important sign of loss of track is the development of posterior open bite. A lot of cases. Sooner or later, you will notice, as you see here in this case, a posterior open bite. The teeth are following the aligner very perfectly, but there is a posterior open bite developing in the posterior area, molar area mostly. That's because of the aligner thickness. The aligner thickness will act as a bite turbo, allowing the patient to allowing the teeth, especially posterior teeth, to intrude. In addition to that, the biological response in the posterior area in general is faster as compared to the anterior area. Maybe because the patient constantly biting and on their posterior teeth, it's act like a chewy, constant chewy, not only temporary. So therefore, there will be a faster intrusion in posterior area, leading to the development of open bite posteriorly. Sometimes that intrusion effect is beneficial, such as in cases of open bite. Intrusion of posterior teeth will close the bite anteriorly. Therefore, why the aligners are very effective in open bite cases. I use them a lot in open bite cases. But it might not be helpful in perfect occlusion or in deep bite cases where we want to, in contrast, we want to extrude the posterior teeth. Once this problem develops, it's possible to solve it. It's not an issue, but you should identify it. You can place elastics, buttons, and vertical elastic, and it will close it quickly. But if it remain or it's advanced and become more complicated, it might lead to incomplete aligner seating and sooner or later loss of track. So, when to intervene? Intervention essential when loss of tracking is greater than 1 millimeter, whether horizontal or vertical, or in case of attachment loss. If your attachment has been lost, you should rebond the attachment. If your attachment is weird or abraded, you should correct that issue other than leading to the development of more complicated issues such as loss of track. If there is a poor fit of more than one aligner, that means there is an issue. You should address it, especially during the middle of treatment. That means that the error is in the patient or in your management of the case. So you should follow up. You should follow it carefully and correct the issue, whatever it is. You should not wait for refinement. Whenever you have an issue, especially early issue, middle treatment issue, we ask for the company, please do refinement. There is an issue in the treatment. No, asking for a refinement when there is a problem in the case is just repetition for the same error. You should correct the cause. We should address the cause. Then we ask for a refinement. Sometimes the cause is in the patient, as we said, compliance issue. Sometimes alignment, attachment issue. You should correct it, then ask for a refinement. Not asking for refinement before addressing the patient compliance or addressing the attachment issue, because as we said, this means that we are just repeating the problem. The clinical tools that improve tracking, one of which are chewies. Chewies are, as we said, are essential tools to improve tracking. They are particularly important in rotational tooth movement, in intrusion tooth movement, and when we bond a new attachments. Chewies, there's a specific chewies protocol. Patient should use it at least 3 times a day for 5 to 10 minutes with the intrusion, as we said, rotational tooth movement, and when bonding a new attachment or inserting a new appliance. Chewies will help to ensure a proper fit of the appliance. Proper fits mean proper progress of the treatment and success of the case. Also, another important tool to improve tracking is slower aligner change. I personally prefer slower aligner change. I do aligner change every 2 weeks because I believe what you gain quickly, you lose it quickly. I don't recommend changing the aligner every 2 weeks or 10 days, rarely 10 days. Because, as I say, what I believe in what you gain quickly, you lose it quickly. And we should admire the biological response. We should allow enough time for periodontal remodeling and bone remodeling to occur. Then after that, we can change our aligner. For the next one. Another important tool are attachment rebonding. As we said, if we have lost our attachment or the attachment got abraded or weird, attachment rebonding is essential as soon as you discovered it. You can use the same template, the first template, if it's occur immediately in the first week, or if it's occur during a treatment, like middle treatment, you can use the last aligner that the patient used. For example, the patient used aligner number 5. He finished it. You can use aligner number 5 or even aligner number 4. For rebonding of the attachment, planned overcorrection is also essential because aligners are made of plastic. They are unable to fully express the planned tooth movement. So sometimes we see that after in the tracking video, you can see that the tooth is fitting perfectly, but in the aligners, the tooth is fitting perfectly, but in a clinical case, the case in front of you, it's not moving. There's a 0.5 millimeter or 1 millimeter that need to be moved further. This is, as we said, because aligners does not allow full expression of the planned tooth movement because of the flexibility of the material. So, another aspect that we will talk about today is troubleshooting. Troubleshooting in clear aligners, including identifying the problem and finding the appropriate solution for that problem. That will help us to realign the treatment with the biological response and the correct biomechanics. So, in general, why aligner cases fail? As we said, majority of the aligner cases fail not because of poor planning, but because of mid-treatment error such as improper follow-up, inadequate or incorrect clinical intervention. So the main reasons are inadequate follow-up, late clinical intervention, ignoring biological limitation. We should put in our mind that some tooth movement are not possible, or even if they are possible, they will be extremely slow, such as the movement of dilacerated teeth, dilacerated roots. We should expect that these two, the ankylosed tooth, we should check it. These teeth, even if they are moved, they move very slowly. Teeth with short roots, even though they moved faster than other teeth, leading to unpredictable outcome. All these should be addressed carefully in the planning and diagnosis of the case. In general, aligner treatment include a complex interplay between biology, mechanics, and with technology. Therefore, the aligners problem in general, including biological problem. The biological problem, we mean the patient problem, such as pain, compliance, and whatever. Mechanical problem means aligners and attachment problem. Digital and planning problem with clear aligners, meaning the technology error, software error. We will address it soon. So, what are the biological problems? The first biological problem and the most important biological problem is patient compliance. Poor compliance leading to failure of treatment and problem in treatment. If we did not address it as soon as possible, it will lead to treatment failure. Another important biological problem is pain. If the patient have pain as he wears the appliance, severe pain, it will cause mild pain, usually the aligner, but not severe pain. So pain will produce reducing wearing time and error in the treatment. So if the problem is about compliance, you should re-instruct the patient about the importance of wearing the clear aligner and importance of consistent use of elastic. You should use elastics with the aligner for 22 hours per day. If it's about pain, in case of severe pain or moderate pain, you can instruct the patient to wear it for at night initially. Then gradually you can increase the wearing time until adaptation occurs. If there is a periodontal limitation, such as gum recession, inadequate amount of bone, this should be addressed during the planning, such as using auxiliaries, using couple force, planning retraction, then a brightening to prevent any damage to periodontia. If there is a root morphology issue, as we said, dilacerated roots with abnormal apex, all these will cause a biological problem. This problem all should be addressed during the planning stage. Reduced staging or slower tooth movement should be planned instead of moving the tooth 0.2 millimeter per aligner. We can move it 0.5 or 0.1 millimeter per aligner. Regarding the mechanical problem, as we said, means that there's an attachment issue or aligner issue. If there is an attachment issue, we should check the attachment every visit, check for the shape of the attachment, the presence and integrity. Attachment loss will lead to mechanical problem, so it should be addressed as soon as possible. It will lead to poor rotational control if the attachment design is inappropriate, as we said, or the attachment is lost or abraded. It will lead to poor rotational control. The teeth will not move effectively as planned, reducing the treatment efficiency. So, careful design of the attachment and rotated teeth. As we said, the attachment should be wider to allow the precise moment, the adequate moment that produce tooth movement. Using couple force system is possible and help to control the rotation with a clear aligner. Another mechanical problem is intrusion failure and extrusion failure. Aligners in generally are very good in intrusion tooth movement, but they are weak in extrusion movement. But however, if there is a difficulty in intrusion, you cannot gain adequate intrusion, you are sure of the patient compliance, the attachment design, but you are not getting enough intrusion. You can use studs. You can use studs and elastic, and you can do intrusion tooth movement, but you should make sure that you remove a small amount, slowly from the gingival margin of the aligner, so that during intrusion, it will not interfere with the gingiva. If you are having an extrusion difficulty, as we said, aligner in general are not very good in extrusive tooth movement, you can use elastics, whether anterior elastics for open bite cases or posterior elastics for deep bite cases to produce the desired extrusion. It's not very complicated and we do it all the time. Another important problem is the digital and planning problem. In general, attachments and software show you what is possible, but not show you what clinically predictable. It smooths the teeth, but not all these movement is possible in real life situations. These problems include over-ambitious tooth movement, meaning over planning of the tooth movement, which not all of it can be gained, as we said, because of the aligner nature. Lack of overcorrection. An essential step is overcorrection, especially in rotational tooth movement. Overcorrection is essential to prevent any errors and to make sure that the treatment is going as desired. If you did not do overcorrection, you will not get the perfect results that you want. Incorrect attachment design. As we said, attachment design is essential for many type of tooth movement, rotational tooth movement, intrusion tooth movement, extrusion, uprightening. For rotation, we use wider attachment. For extrusion and intrusion, we use an inclined surface attachment to produce the desired vector for tooth movement. So, refinement. Is a refinement a failure? We did all the previous steps to avoid refinement. Does that mean that if we ask for a refinement, it's a failure? No, it's not. All the cases need at least one refinement, but this refinement should not be done very early during the treatment, maybe during the middle course of the treatment or the final stage of the treatment. But why? Refinement are done to improve tracking, to improve occlusion, and to improve finishing details. If you have a small open bite, a small rotational error, small occlusion error, you can correct them with refinement. It's okay. But not from the early beginning, as we said. If we asked for refinement from the early beginning, we are repeating the same mistake, not correcting the problem. Another important topic we're going to talk about today is elastics. Elastics are important tool with clear aligners because of the nature of clear aligners. As we said, it's made of plastic. Therefore, complete expression of tooth movement sometimes is not possible. But with the development of the material, we can address majority of the problem, but elastics are still essential too. So, as we said, aligners alone cannot deliver full biomechanics, and elastics will help the aligner to control sagittal discrepancy, vertical dimension, midline correction. All these problems can be corrected successfully with the use of elastic, which helps us to treat more and more complicated cases with the aligners. Regarding the types of elastics, as with fixed orthodontic appliances, there is different types of elastics. Class 1 elastics, which is an intra-arch elastics used with aligner for retraction of teeth mainly, or derotation of teeth. Class 2 elastics used to correct class 2 malocclusion on overjet correction. Class 3 for correction of a class 3 malocclusion. Vertical elastics can be used for intrusion or extrusion according to your treatment plan. And midline correction elastics is also an important tool with the clear aligners. So, using elastics with aligners, we mainly focusing on the force and the size. The most important thing is the force and the size. The force should not be heavy. We focus on using light and medium force. It's essential. Heavy force should be avoided because excessive force will increase pain and produce tipping tooth movement. Tipping tooth movement generally are not desired and leading to non-compliance. If the patient develop pain or have ill-fitting aligner because of inappropriate use of elastics, this will lead to non-compliance. Additionally, we focus on using maybe smaller diameter elastics. I prefer using a smaller diameter instead of larger diameter because larger diameter elastics will disengage faster. So if I have to choose between 1/8 or 3/16, I will prefer using 1/8 elastic because it's fit better for the teeth. Also, it's according to the clinical situation. You can choose your appropriate elastic. So the biological efficiency is much more important than the force magnitude. Heavy forces should be avoided to prevent undesirable side effects. Regarding the most common elastic mistakes, incorrect vector. Incorrect vector is an important problem with aligners, with elastics and aligners. If you are planning to doing extrusion tooth movement or intrusion, vertical vector is more important than horizontal vector and more essential. If you are planning for retraction, for example, horizontal vector will be more beneficial, but sometimes it's combination according to the clinical situation. Poor patient instruction. As we said, patient should be compliant and should use elastic consistently with the clear aligner. If the patient did not use the elastic consistently, that will lead to that will lead to ill-fitting aligner and decrease the treatment efficiency. Another problem with the elastics is late introduction. Late introduction of elastics, a lot of doctors I sometimes see, when you have planned tooth movement with elastics, they did not use it from the first day. They use it later during the treatment. This will lead to unpredictable outcome and ill-fitting aligners, and the case will not follow normally. So early introduction of elastics is essential as a plan, sometime from day one. Elastics application is essential. Patients should be instructed and they're used. Some cases, the elastics can produce in a growing patient can produce skeletal effect. So we should instruct them and encourage them on using elastic from the first treatment, from the beginning of treatment. Always instruct your patient using the mirror, teaching them how to wear the elastics in front of the mirror or on the, say, chair side, or using a mannequin or the patient cast. Also, you can also allow the patient to take photos with the elastic in their phone so that they can use it appropriately. Consistent wear and knowing how to apply the elastics is essential for the success of the treatment. So we talk about majority of the issues, troubleshooting issue, elastics, and follow-up with the clear aligners and with Sagalign. Now I want to talk about some of the points, which is using the accessories. Every every piece in that elegant box is made for a purpose. Uh, they are meant to be here. Many patients don't use it. Many doctors does not instruct their patient to wear them or to use them. So, one of which is the aligner case. So, I'm going to talk about the aligner storage. Why aligner storage matters? It matters because it prevents distortion. Distortion meaning loss of track, failure of treatment. It reduces biofilm formation because if you put your aligner in a humid environment or in a hot environment, all this will affect on biofilm formation, especially in humidity. Increasing biofilm formation will lead to poor patient compliance. It's an effect on the odor of the appliance, bad odors, meaning patient non-compliance. Any discoloration if in aligners also reduce the patient compliance. So proper aligner storage is essential for improving patient compliance. And if you saw that your patient, or if you find that your patient is not storing the appliance appropriately, that's a sign of a hidden non-compliance. So, where to store the aligner? The best place for replacing the aligners is the patient mouth. The aligner should be in the patient mouth for 22 hours per day, as we said. But during the time where the aligners are not in the patient mouth, such as during eating, during brushing, it should be stored in its case. It's a beautifully made case, ventilated, rigid case. The aligner should be dried before storage. Avoid putting the aligner in the tissue or in your pocket as will be destroyed or distorted. Avoid a humid environment and hot environment because aligners are made of plastic materials and they will quickly dimensionally change when you store them in a hot or humid environment. Another important tool that is essential and to improve patient comfort, compliance, prevent cracking, prevent distortion, and preventing attachment loss is the aligner removal tool. Aligner removal tool is very important. It's helps the patient to remove the aligner and help you also during the first attachment, first bonding date. This will help the patient to remove the aligner easily and quickly, which might improve their comfort, as we said, compliance, prevent cracking, distortion, and attachment loss. Aligner removal tool is usually started from the posterior lingual area, whether upper and lower, gently disengaging the aligner from the teeth, then moving it anteriorly. Start from posterior lingual, then move slightly to anterior zone. You should avoid, and your patient also should avoid pulling the aligner from the incisal edge as it will produce the distortion of the aligner and might lead to attachment loss. Another important aspect I like to talk about is that you instruct the patient to do is aligner cleaning. Aligner cleaning is essential. As we said, it will improve patient compliance because the most important aspects of the aligners are the aesthetic aspects. They should be transparent. If there is a biofilm or plaque accumulation, that will lead to loss of transparency of the clear aligners and reduce patient compliance. How to clean the aligner? Very fine or soft toothbrush should be used under tap water and soap only. This is the method to clean the aligner. You can use also a lot of aligner care material that can be used for disinfection and cleaning and aligner according to new manufacturer instruction. Majority of them can be used once daily. The aligners should be cleaned before insertion, or when the patient finishes eating, he should brush his teeth, clean the aligner, and insert it in his mouth. During cleaning, we should avoid hot water. We should avoid abrasive toothpaste. Toothpaste in generally are abrasive, containing abrasive material, might lead to distortion of the appliance and the template. Avoiding bleaching and alcohol in the aligner, as well it will lead to abrading the aligner and loss of integrity. Placing the aligner, and so this is a trend, a new trend, many patients place their aligners in the dishwasher to clean them. It's incorrect because there is a heat. Heat will cause distortion of the aligner. Likewise, boiling the aligner is not allowed. It will affect on transparency, compromising transparency and the fit of the aligner. So we finished the troubleshooting, the follow-up, and the elastic use with the aligner. Now I'll show you two cases about that I treat them with the clear aligners. I couldn't prepare more because I didn't have enough time. So this is the first case. The case is having proclination and spacing of the upper anterior teeth. Patient is female patient, about 40 years old, asks for an aesthetic appliance. She has previously treated her teeth with a fixed orthodontic appliance, but relapsed because inappropriate treatment and because she didn't put a permanent retainer. So we managed this case with a clear aligner. The aligner was introduced after 10 days. After that, this is the finishing. This is the finished case. Very beautiful smile, well-aligned teeth, spaced all closed. The main issue is the posterior open bite in this area. I didn't use elastic because it's very simple and sometimes it will close soon after without any intervention, allowing a biological response and settling. It will close by its own. The second case is this case, Marwa. Marwa have proclination and spacing upper anterior teeth, lower anterior teeth crowding, and spacing posteriorly, and extrusion of upper premolars. She wanted to do implant, but she couldn't because of inadequate space in this zone and in this zone, because of inappropriate space distribution. She asked for an aesthetic appliance to correct this issue and to address these problems. So we choose clear aligner. The digital setup showed us that all this movement is possible. Beautiful attachment design. We planned retraction of upper anterior teeth. Sorry, we planned retraction of upper anterior teeth. There's something in the video. Retraction of upper anterior teeth, retraction and alignment of lower anterior teeth, space redistribution, visualization of the premolars to open the space and to intrude the upper premolars in the left quadrant to produce a sufficient space for the placement of implant. The case progressed very good, and the aligners was introduced after 10 days, and this is the final outcome of the treatment. but I asked for refinement because there's a small space between the first premolar and second premolar, and between the canine and the first premolar. I asked for them to close the space. Then after that, patient will do implant. And she was very happy with the treatment. The most important thing is the intrusion effect. I saw this case, I didn't use that, but however, we gained a beautiful intrusion in the left quadrant in the premolar zones, even without the use of TATs, because of the correct design and the correct attachment design. So, to take home message, planning, start the case, follow up, control the case, and elastic, define the finishing quality. And thank you for your time. And it's an honor to be here with you. Hope to see you again soon.